Hyponatremia, defined as a serum sodium Na+ concentration less than 136 mg/L, is the most common electrolyte abnormality in hospitalized patients and is associated with significant morbidity and mortality. The relationship between hyponatremia and brain damage is strong and reciprocal. Indeed, many neurological diseases are associated with hyponatremia, and hyponatremia itself can cause serious clinical diseases affecting the central nervous system. Common neurologic disorders, including subarachnoid hemorrhage, cerebrovascular accidents, brain tumors, and head trauma, can cause hyponatremia secondary to a syndrome of inappropriate antidiuretic hormone secretion, encephalitis wasting syndrome or ADH. In response to injury, the brain secretes natriuretic peptides. In addition, many drugs that affect the nervous system are used in neurosurgical or neurological, psychiatric patients. The clinical manifestations of hyponatremia are primarily related to central nervous system dysfunction and are most pronounced when serum falls rapidly. Hyponatremic encephalopathy is a common consequence of cerebral edema secondary to acute hyponatremia and accounts for 34%. Chronic hyponatremia is related to the adaptive response to brain cell swelling and is called subclinical, or disease with PORC symptoms. However, there is recent evidence that chronic, mild hyponatremia is associated with significant clinical outcomes, particularly those affecting bone and the nervous system. Also, if not corrected properly, hyponatremia can lead to irreversible brain damage. Signs and symptoms of hyponatremia include nausea and vomiting, radiation, loss of energy, drowsiness and fatigue, anxiety and irritability, muscle weakness, stiffness or spasms. Brain injury can disrupt the blood-brain barrier, causing brain edema and increased intracranial pressure. Osmotic therapy, mannitol, hypertonic saline, is initiated in patients with brain injury and cerebral edema and increased intracranial pressure after a number of treatments, such as drainage of cerebrospinal fluid, have failed. The addition of hypertonic saline can increase fluid and sodium retention, often resulting in hypervolemic hyponatremia. Also mannitol. Although intracranial pressure is reduced, osmotic diuresis often results in loss of sodium and water, resulting in hypovolemic hypernatremia.